We're going to shift gears now and discuss parathyroid hormone, or PTH, and the regulation of calcium and phosphate. The key things to know about PTH are that it increases serum levels of calcium and decreases serum levels of phosphate. A helpful way to remember this is to treat PTH as the acronym for phosphate trashing hormone. Let's take a closer look at the ways it accomplishes this task. PTH is produced by the chief cells of the parathyroid gland. When ionized calcium levels in the blood are low, the parathyroid gland releases PTH to increase calcium. One function of PTH is to increase bone resorption of both calcium and phosphate. Interestingly, PTH directly stimulates osteoblasts, and the osteoblasts go on to induce osteoclasts to do the actual resorptive work. The other actions of PTH occur in the kidney. First, PTH directly causes increased reabsorption of calcium in the distal convoluted tubule. Simultaneously, it causes decreased reabsorption of phosphate. Lastly, PTH stimulates 1-alpha hydroxylase in the proximal tubule of the kidney, which increases the production of active vitamin D, the 1,25-dihydroxy form, also known as calcitriol, and this goes on to increase intestinal calcium and phosphate absorption. Once again, the overall effect of PTH is to increase serum calcium and decrease serum phosphate. A final aspect of the hormone that is important to know is that it can be affected by serum magnesium concentration. When the magnesium concentration is low, PTH secretion is decreased. This low magnesium state is seen in patients with diarrhea and alcohol abuse, as well as those taking aminoglycosides or certain diuretics. Now, we already started to discuss vitamin D above in relation to PTH, but let's concentrate on just vitamin D for the moment. This is a critical vitamin with important functions in mineral homeostasis. The D3 version comes from sun exposure, and the D2 version is ingested from plants. The liver is responsible for hydroxylating each version at the number 25 position, and the kidney is responsible for hydroxylating at the number 1 position. Hence, generating the active form of vitamin D, known as 1,25-dihydroxy vitamin D, requires both a functional liver and kidney, which is also why you can see vitamin D deficiency in some forms of kidney disease. We'll see later how this requirement can become a major problem for patients with kidney disease. We now know where vitamin D is coming from and how it is modified in the body, but what exactly does it do? Its main function is to increase the absorption of calcium and phosphate from the GI tract, and additionally, vitamin D acts to increase bone resorption of calcium and phosphate. Like PTH, it increases serum calcium levels, but in contrast to PTH, it increases phosphate levels as well. There are two forms of vitamin D deficiency. In children, it is known as rickets. In adults, it is called osteomalacia. More on that in the musculoskeletal lectures. Vitamin D production is stimulated by increased PTH, decreased serum calcium, and decreased serum phosphate. Vitamin D also exhibits feedback inhibition on its own production. Another aspect of the calcium story comes from the hormone calcitonin. This molecule is usually not relevant to normal calcium homeostasis, but it is sometimes used as a drug to combat hypercalcemia. The function of calcitonin is to decrease bone resorption of calcium. We like to say that calcitonin tones down serum calcium levels, though repeated studies in humans show that its effects are minimal at best. The endogenous source of calcitonin is the parafollicular or C cells of the thyroid gland, and secretion is increased by high serum levels of calcium. We won't talk about this section, but you should take time after the lecture to review the pathways. One valuable way to study is to cover up half of the table with a piece of paper, and then force yourself to actually write down what you expect to see under the paper. Then cover up the other half of the table, and do the same thing. Let's now briefly review the mechanism by which steroid hormones function. The key thing to remember is that steroid hormones, such as testosterone, are lipophilic. There are two important consequences of this chemical feature. First, steroid hormones can pass freely through cell membranes and into the nucleus. And second, they are insoluble in plasma and are carried by specific molecules called binding globulins. Steroid hormones pass through the lipid bilayers that compose cell membranes and interact with receptors either in the cytoplasm or nucleus, which then adopt a conformation able to bind DNA to alter gene expression. Thyroid hormone has a similar mechanism of action as steroid hormones, and indeed there is a shared family of steroid and thyroid receptor molecules. As you can imagine, since these hormones act by altering gene expression, their effects take time to manifest. Contrast this to the rapid effects of a peptide hormone such as insulin, which causes an immediate increase in glucose uptake by cells, enabling cellular respiration and ATP production. Binding globulins increase the solubility of the steroid hormones they carry and improves delivery to target tissues. The serum level of binding globulins often has clinical relevance. For example, sex hormone binding globulin, or SHBG, is the specific carrier for sex hormones such as testosterone. Increased levels of SHBG lower the amount of free testosterone. In men, decreased free testosterone manifests as gynecomastia. When the levels of SHBG drop in women, there is more free testosterone in the bloodstream, which manifests as hirsutism, which is male-patterned hair growth. Let's move on to discussing thyroid hormone. The pathological conditions of hypo and hyperthyroidism are absolutely critical to know for the USMLE. Thyroid hormone is produced in follicular cells, also known as thyrocytes, of the thyroid gland. It contains iodine and controls the body's basal metabolic rate. You can see in this diagram of a follicular cell that thyroglobulin protein, or TGB, is produced in the cytoplasm and secreted into the lumen. In parallel, iodide ions are taken up by follicular cells via a sodium-iodine cotransporter, oxidized to diatomic iodine, and then secreted into the lumen. In the lumen, thyroid peroxidase is responsible for adding iodine onto tyrosine residues of thyroglobulin. Upon stimulation by TSH, iodinated thyroglobulin is endocytosed from the lumen back into follicular cells, where it is digested by lysosomal proteases to release monoiodotyrosine, or MIT, and diiodotyrosine, or DIT, into the cytoplasm. Combining MIT with DIT results in triiodothyronine, also known as T3, whereas combining two DIT molecules results in thyroxine, also known as T4. These two forms of thyroid hormone are then transported across the basolateral membrane of thyrocytes and into the bloodstream in a TSH-mediated process. Thyroid peroxidase is a versatile enzyme. Not only does it incorporate iodine into thyroglobulin, a process known as organification, it is also responsible for oxidation of iodide ions and coupling MIT and DIT to form thyroid hormone. It's worth pointing out that T4 is the major product of follicular cells. Though some T3 is produced in the thyroid gland itself, the majority of T3 in the body is derived from peripheral deiodination of T4, specifically a removal of the 5' iodine by 5' deiodinase. You can consider T4 to be a prohormone for T3, since T3 is much more active than T4. Okay, let's turn now to the functions of thyroid hormone. As we already noted, the major role of thyroid hormone is to control the body's basal metabolic rate. How does it do that? In brief, thyroid hormone increases sodium, potassium, ATPase activity and expression, which increases oxygen consumption, the respiratory rate, and body temperature. It also upregulates glycogenolysis, gluconeogenesis, and lipolysis to increase ATP production. Additionally, thyroid hormone upregulates the number of beta-1 receptors in the heart, which leads to an increase in heart rate, stroke volume, contractility, and therefore cardiac output as well. This is the reason why hyperthyroidism is associated with palpitations. There are two other critical functions of thyroid hormone in the developing body. It promotes bone growth along with growth hormone in a synergistic fashion, and it promotes maturation of the central nervous system. Patients with thyroid deficiency early in life develop neonatal hypothyroidism, or cretinism, which is characterized by severely stunted physical and mental growth. For example, short stature and low IQ. You may find it helpful to think of thyroid hormone in terms of the 4 B's: brain maturation, bone growth, beta-adrenergic effects, and increased basal metabolic rate. Like steroid hormones, thyroid hormone is transported in the blood by a binding globulin, thyroxine binding globulin. TBG binds most of the T3 and T4, and the only thyroid hormone that actually acts on the tissue is the fraction of free, unbound thyroid hormone. Lab tests are available to measure the total amount of hormone, as well as the free portion of the hormone, to allow clinicians to understand the source of changed hormone levels. Two situations in which this is relevant are in hepatic failure, when the TBG level is low. and pregnancy when the TBG level goes up. So in pregnancy, for example, the TBG is high and the total amount of thyroid hormone is high, but the amount of free hormone should stay constant and therefore the patient is considered to be euthyroid. Make sure you don't confuse TBG, or thyroxine binding globulin, a carrier of thyroid hormone in the blood, and TGB, or thyroglobulin, the precursor of thyroid hormone. Graves' disease is an autoimmune condition in which production of thyroid-stimulating immunoglobulin, or TSI, in large quantities stimulates follicular cells in a manner similar to TSH, resulting in hyperthyroidism. Two common antithyroid drugs used to treat hyperthyroidism are propylthiouracil, or PTU, and methimazole. While PTU inhibits both thyroid peroxidase and 5' deiodinase, methimazole only inhibits peroxidase. Both drugs take time to have a clinical effect because they block synthesis of thyroid hormone but do not deplete existing stores. Interestingly, excess ingestion of iodide can lead to a transient decrease in thyroid hormone levels because of the iodide pump inhibition. This phenomena is known as the Wolff-Chaikoff effect.